Hi guys, so first order of business is to tell you about how cool my robe is. I highly recommend that you guys all get one of these. It's like from the 90s and I wear it on my day off when my kids are otherwise being supervised by an adult. Second order of business is talking about high output heart failure. This is a hyperdynamic state distinct from low output systolic dysfunction, characterized by an elevated cardiac index over 4 liters per minute. This happens from systemic demands exceeding compensatory capacity, yielding biventricular overload, pulmonary congestion, despite preserved ejection fraction. Etiologies stem from hypermetabolic or vasodilatory derangements. This is predominantly from obesity with a BMI over 30 with augmented oxygen consumption. Also, advanced cirrhosis, including splanchnic vasodilation and hyperdynamic circulation, can cause this. Iatrogenic or pathologic AV fistulas from ESRD can also cause low resistance shunting. Profound anemia can precipitate tissue hypoxia, requiring a higher cardiac output to deliver oxygen to tissues, which can cause high output heart failure. Thyrotoxicosis, accelerating basic metabolic rate, can also cause this. Wet beriberi from thiamine deficiency, and more rare is Paget's disease. There's also gestational physiology, septic shock, or plasma cell dyscrasias like multiple myeloma can also cause this. Diagnosis requires vigilance for atypical seminology, dyspnea, orthopnea, edemia, yet with warm extremities, bounding pulses, and wide pulse pressures, contrasted entirely to low output states. Transthoracic echo reveals hypercontractility and chamber dilation. And then you're going to need to confirm this diagnosis with a right heart cath demonstrating supernormal cardiac output, reduced SVR, and elevated filling pressures. Exclude things like comprehensive serology, CBC for anemia, TSH, LFTs, multiple myeloma screens. Therapeutics prioritize causal reversal, often curative in contrast to HFrEF. For obesity, bariatric interventions yields hemodynamic normalization. Anemia requires IV iron or transfusion. And you can also do surgical AV fistula ligation or reversal. If you have advanced cirrhosis, you can get a liver transplant. Symptomatic palliation employs loop diuretics for volume, RAS inhibition, and beta blockade to mitigate tachycardia and basically to avert output collapse.